Okay, let's go with another start here. We really want to welcome you to our breakout session, and we'll take a few minutes just to introduce ourselves. And I'll get back here. Excuse me. All right, I am Deb Sid. I'm an educator at Normandale Community College and also with the Bachelor of Science Dental Hygiene program at Metropolitan State University. I'm an online course instructor. I am the partnership liaison, and I am the program chair. So fun hats to hold, and very active with the HRSA grant. And my colleague here is Rachel.
Hi, I'm Rachel Kashani-Legler. I am also an educator at Normandale Community College. In addition, I work as a clinical dental hygienist, and I represent the Minnesota Dental Hygiene Educator Association to the Board of Dentistry.
Uh-oh. So what we would like to share with you, and we're eager to share this with you, is a $1.6 million grant that Normandale Community College received in July of 2015. We received this grant from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. It's a 5-year grant entitled Innovative Pathways to Advanced Practice for Dental Hygienists, Meeting the Needs of Minnesota's Underserved Populations. Our HRSA grant emphasis is on workforce, with our main intent to advance the role of the dental hygienist to expand our reach to oral health care for the vulnerable, underserved areas and populations. Okay, we have 3 dynamite partners here that are working cohesively together for the success of the grant: Normandale Community College, Metropolitan State University, and the Minnesota Department of Health. Along with us is Delta Dental Minnesota Foundation. They really did jumpstart this HRSA grant because initial funds were obtained through Delta Dental Foundation to support some assessment data, and then we were able to propose our HRSA application. They are continuously supporting us and also adding those supplemental funds that we need in the process with our activities. Okay, I'm going to talk about goals. We have 4 main goals with our HRSA grant. And I'm going to just give you an overview of the 4 goals. What Rachel and I will do is get into emphasis on goal number 1 for the majority of our presentation. Okay, so goal 1 is to strengthen the collaborative practice infrastructure. How do we intend to accomplish this goal? You look at the 2 bullets there, those are our objectives. We think we can accomplish this by increasing the number of collaborative practice agreements between licensed dental hygienists and dentists. We also then will increase the number of dental hygienists pursuing and obtaining successfully a baccalaureate degree in preparation for collaborative practice. So goal 2, what we want to do here is ensure access to preventive and primary health care services, making sure that these services are readily available to more members of the underserved populations, especially in our rural areas and in greater Minnesota. We've got 3 objectives there. That first bullet is kind of a passion of mine, and I also have several students here who are involved in that. What we're doing is Normandale and Metro State, through a partnership, are allowing our students to be duly admitted and enrolled in an educational pathway that is so innovative. What it is the associate degree student, while taking those courses in clinical work, are online working with baccalaureate courses, and simultaneously they will very quickly, maybe 3 weeks, 4 weeks beyond receiving their AS degree, will have their baccalaureate degree. If they're real go-getters. That's if they really go heavy, right? And you guys can probably acknowledge that. Or you take a path where I'm going to slow myself down a little. This curriculum is pretty tough here this semester, and I end up maybe a year after with my BS after having obtained my associate degree. So what we're trying to do with that is expand that to other Minnesota State 2-year dental hygiene programs within the state of Minnesota. We're doing great with this. Actually, we're doing awesome, because on board we have M-State in Moorhead, we have Century College, Lake Superior College, and soon to join us is Rochester Community and Technical College. And it's so exciting, even at our home campus with Normandale, but I get out there and I do meet these students who are so thrilled to be able to follow in this innovative educational pathway, thanking us for the opportunity. Okay, another bullet here, so I'm going to call that objective number 2, and that is replicating the advanced dental therapy program that we have on our Metro State campus today, that we would have that the home site, but a clinical area out in greater Minnesota where students can be doing their clinical application and coursework. So innovative in the sense that we will be working with online synchronized teletype communication for the basic courses, but that clinical site being out there in greater Minnesota hopefully will, with bullet 1 and 2 there, obtain an increase in the number of rural sites at which dental hygienists and advanced dental therapists can practice in the state of Minnesota. Thanks, Rachel. Okay. Goal 3. Okay, this one is very close and dear to my heart too, because I have an opportunity to work with a health expert, content expert at the Minnesota Department of Health to thread through the curriculum of the baccalaureate program along with the ADT program content in the curriculum that emphasizes cultural competence, health literacy, and basically health equity. So what we're doing with that is trying to create innovative, active learning modules, applying good clinical application to, for especially the ADT students, because our baccalaureate students aren't in any clinical form of practice, but we sure can carry that cultural competence and health literacy and concepts of health equity right into the ADT clinical application. Because our program is so flexible, because our program is that flexible, you know, with the online format, we then can encourage qualified students who are in our underrepresented populations, if that makes sense. We got to reach out there and encourage that they can do this online coursework and be successful where they live, whether that might be up near Duluth, you know, out near Moorhead, Hawley. We spent some time in Hawley, Minnesota even, which is just outside of Moorhead. But it's where we need to be, so we want to reach those students who are very motivated and interested. And goal 4, which is our final goal, is to maximize the opportunity that Minnesota has with this to provide leadership with our innovative workforce models. Very, very excited about this in the sense that that's why we're here today. That's why we are doing poster sessions. We're developing a new website. Claire, I just saw you. Claire is heading that up on our campus at Normandale, that there'll be a wealth of resources for you and a wealth of resources for any collaborative practice dental hygienist out there needing some guidance too. Nationally, we're at conferences, so statewide, we will spend some time out there with some information sessions too in greater Minnesota to really get people informed and actually excited about this opportunity. Okay, now, this is where we kind of turn and say, okay, there's 4 goals, but today the one we really want to work with you on is goal number 1. And Rachel's going to take this over and get into some explanation first, and then we'll get into the changes that we propose.
All right, so as Deb said, our focus is goal number 1, which again is to strengthen the collaborative practice infrastructure. And through that, our intent is hopefully to extend the reach of dentistry to more underserved Minnesotans by better utilizing our current dental hygiene workforce and future dental hygiene workforce. All right, I'd first like to begin with some background on the current collaborative practice model, which is also known as Limited Authorization for Dental Hygienists Minnesota Statute. It was initiated in 2001, and what it does is it allows a dental hygienist, after 2,400 hours of experience within an 18-month period, to enter into a collaborative agreement with a licensed dentist to provide dental hygiene services in a non-traditional setting. Dental hygienists who are practicing in this manner may be employed or retained by a healthcare facility, program, or nonprofit organization. Examples of sites include, but are not limited to, a hospital, a school, a group home, a home health agency, Head Start program, and many more non-traditional sites. All right, so what is a collaborative agreement? It is a written document that is formed between a licensed dentist and dental hygienist, and it really designates authorization for the services to be provided by the dental hygienist in a non-traditional setting. With that collaborative agreement, the dental hygienist can treat the patient without the patient first being examined by the dentist. As well, the dentist does not need to be on site for the dental hygienist to perform their services. Okay, so since 2001, the last 15 years, collaborative practice has really been underutilized. So we're taking action now to make some changes to the statute that hopefully will improve access to more Minnesotans. And with these proposed changes, we are going to bring them at the next legislative term here in the upcoming 2017, with the hope of them being enacted in 2018. So, how did we get started? So I personally became deeply involved with the HRSA grant, specifically Goal 1, to strengthen the collaborative practice infrastructure with my graduate studies in community health education. And I chose collaborative practice as my thesis topic. And through my research, the process and the outcomes, I was able to inform the Collaborative Dental Hygiene Practice Advisory Committee and provide some direction and discussion for those members. And they're the ones who really put together these proposed changes that we are presenting today. So who are the Collaborative Dental Hygiene Practice Advisory Committee? We have many key stakeholders on that committee. I do want to look at my notes because I want to make sure that I do make reference to all of those individuals who are represented. But we have individuals from various safety net clinics, the Minnesota Department of Health, the Minnesota Dental Hygiene Association, the Minnesota Dental Association, Delta Dental of Minnesota Foundation, the Minnesota Oral Health Coalition, as well as collaborative practice dental hygienists and advanced dental therapists. We have dental educators, or dental hygiene educators, and a member from the Board of Dentistry, as well as someone representing, or who is representing the Department of Human Services. So we have many key players that are involved in what we're sharing here today with you. All right, so we're going to get on to our proposed changes. We do have 11 proposed changes that we are going to share with you today. And at the end of our presentation here, we would like to get your feedback. So we have a survey that we will be handing out in regards to these specific 11 proposed changes, and you can provide us some feedback. So change number 1, it really encompasses 3 things that we would like to do. First of all, we would like to rename the statute from limited authorization for dental hygienists to collaborative practice authorization, as we feel this kind of clearly represents what the statute's focus is. In addition to that, we would like to identify dental hygienists who work under a collaborative agreement as community health dental hygienists. And then furthermore, we'd like to clarify in the statute that community health dental hygienists working with a collaborative agreement applies only to settings outside of the traditional dental office. All right, so moving on to proposed change 2. We'd like to require registration of collaborative agreements with a state agency. What we feel this would do is allow for better tracking of what type of locations are community health dental hygienists practicing in, where are these locations specifically within the state of Minnesota, and what type and number of services are being provided by community health dental hygienists. We'd also like to know, how many collaborative agreements are being utilized out there, because right now we don't have a full grasp on how many are out there, but we do know that they're being underutilized. So we feel like with registration, we might have a better idea if we are really, making an improvement out there through this practice. Proposed change 3. We would like to allow the community health dental hygienist to perform their entire dental hygiene scope of practice. So right now in the statute, there are a list of specific services that may be provided by the dental hygienist under a collaborative agreement, but it doesn't include the entire scope of practice. So what we'd like to do moving forward is get rid of those specific services that are listed and just reference the entire dental hygiene scope of practice. So as there are changes or updates to the scope of practice over time, that will not limit the community health dental hygienist.
Okay, proposed change 4. And what does this involve? This would be allowing the licensed dental hygienist with a baccalaureate degree in dental hygiene to enter into a collaborative agreement providing the dental hygiene scope of practice, and here's where it's key, without any additional postgraduate clinical hours. Why we want to substantiate this thought in your minds is to tell you about the baccalaureate dental hygiene graduate. This student really is invaluable with their competence, their insight in areas of leadership, teaming, evidence-based decision-making, critical thinking, healthcare and patient advocacy, conflict management, project management, all these great things. And what's happening here is the students are driving this. They really are. They're telling us that they want to do this, and they want to do this right when they come in to pursue a career in dental hygiene. So it's so fun to say, okay, you're ready to go, you're empowered, let's get you in the right collaborative agreement, and let's go and let's meet the needs. We will have then an immediate workforce for our non-traditional settings out there in areas and communities that need us. Proposed change number 5. This is where we look at the associate degree graduate, and this is the post-grad, entering a collaborative agreement and able to provide the preventive services of screenings, fluoride treatments, oral hygiene instructions, and dental sealants. So you're looking at preventive procedures there with no required clinical hours once licensed. We want to remove this limitation because it's stopping the associate degree graduate from immediate pursuit of a mentored opportunity to provide the much needed care to underserved areas in alternative settings. Proposed change 6. We want to reduce the requirement of postgraduate clinical hours for the licensed associate degree dental hygienist from what is now 2,400 hours to 400 hours. They could enter into a collaborative agreement and perform the remaining scope of our dental hygiene practice. By decreasing these hours, we're going to take away the barrier. It's limiting right now. What's happening is the post-grad is the one that's so empowered, enthused, ambitious to do this. We lose them if we have 2,400 hours. If we have too much required there, let them get out there and make the proper collaborative agreement arrangement with someone who's going to work collaboratively with them, continue to mentor them. Both will be involved in yearly professional development. Resources are available on our website that we're talking about. There's so many opportunities in practice to learn with experience. And a lot of this, you can't gain this experience unless you get out there and work in those unique areas and populations. Okay, so proposed change 7. Let's look at the licensed dental assistant and how powerful this intraprofessional approach could be for the community health dental hygienist to work side by side with the licensed dental assistant to provide preventative services in their scope of practice in a community-based setting. This impact and intent really is all about improving the efficiency, the cost effectiveness, and even the quality of patient care. And again, ultimately, we're going to really promote that interprofessional dental team approach.
Okay, legal liability has been a stated concern by many dentists who are hesitant to enter into a collaborative agreement with a dental hygienist. So for proposed change 8, we are proposing that community health dental hygienists be required to carry professional liability insurance that will cover them in the non-traditional community-based settings. We're hoping that this might alleviate some of the concerns with liability, as well as it will provide some clear protection for the dental hygienist who isn't working in these non-traditional settings. Okay. Some dentists are also not comfortable entering a collaborative agreement with a dental hygienist because they feel like they have a responsibility to take the patients that are seen by the dental hygienist as patients of record. So we would like to clearly state in the statute that patients seen by the community health dental hygienist do not need to become patients of record with the collaborating dentist. We just feel like clearing up that language might increase some formations of collaborative agreements. All right, this one's a little bit more interesting. The next proposed change encourages the inclusion of other healthcare providers to form a collaborative agreement with a dental hygienist, such as a physician or a nurse practitioner. This would only apply to community health dental hygienists who are working in primary care settings. And we feel that this would allow for true integration of oral and overall health and provide some interprofessional collaboration among different healthcare providers. By doing this, this may increase the number of collaborative agreements and expand access to care. And then for the last proposed change, though this isn't specific to the statute itself, this change, this portion or topic plays a very significant role in the development and utilization of collaborative agreements. The change is to improve processes for more consistent, efficient billing and reimbursement services performed by a community health dental hygienist. So currently, the reimbursement rates for the Minnesota healthcare programs are still among the lowest in the nation. In addition to that, the types and frequencies of billable services is a concern that needs to be addressed. Currently, community health dental hygienists or dental hygienists in general cannot be directly reimbursed for the services that they provide. And it's just a very cumbersome and confusing process to get reimbursement. So what we feel this would do is it would, if a dental hygienist could be directly reimbursed, that would allow for better data collection. It would also alleviate the dentist from having to be responsible for billing, which has been a stated concern by many dentists because it's very time consuming for them to be involved or their staff members to be involved in the billing process. As well, it would just really streamline the whole process itself where the dental hygienist can directly receive some funds for the services that they are providing. The last thing we would like to do is also have community health dental hygienists be reimbursed for screenings and assessments that they provide to their patients.
Okay, we just threw a lot at you, didn't we? I hope you were able to follow comfortably, digest it. I'm hoping that the handouts helped. But this is the point where we want to answer your questions or even open up some discussion. And time-wise, we got some good time because we also need to include time for you to take a survey that will relate to these proposed changes and get your input. Do we have any questions? Okay. Just gotta hold it from down here.
Hold it, okay. I just had a question. I represent the Board of Dentistry on your committee, but have you reached out to the Board of Nursing or the Board of Medical Practice regarding your interprofessional recommendation?
At this point, I don't think we've moved ahead. We need to establish first within our dental professional group stakeholders that that's where we want to head to. But I think that's a great question because that was exactly probably the next step to go, right?
You would have to. It also changes our entire delegation agreement with the Board of Dentistry as well. So there's going to be a lot of changes. But as far as that goes, as far as what you're proposing in the statute, and then also they would have to be involved on their level because we don't at this time allow them to supervise dental hygienists. So it would be something that you have to, if you choose to go that route, you'll have to involve them.
Thank you for that helpful input.
And at this point, I think the route that we would be taking is more so allowing those healthcare providers to be a co-signer on the collaborative agreement with a dentist. And just to get, more interprofessional collaboration among the group, because there are, a lot of processes involved in that.
And specific sites, too. We're looking at medical facilities. Okay, I think there was a question over there. Oh. We'll go this way. There you go. Hi.
Thank you. Peg Simonson, formerly with the Oral Health Services for Older Adults at the University of Minnesota Dental School. I have a similar question, proposed change 10. When you talk about medical and hospital settings, I assume nursing homes are a part of that, right? And in that, I think this is a great idea to get the interdisciplinary piece put in there. In my experience, I would be, the board also spoke to some of their issues with this, but there's going to be an educational component, I think, for the physicians who I've been told by a geriatrician. She said, I was never trained to look at the teeth. I look at the soft palate. And so an understanding by them of what it is that we do to the body, to the systems, and so that may have to be a part of that conversation. The other piece about collaborative practice that I found always difficult as a hygienist in nursing home settings was the piece about if you have a medically complex patient, that the dentist must evaluate the patient first. I wouldn't be able to do a thing in nursing homes if that were the restriction. And so because I worked within a clinical setting that was under the University of Minnesota, we were able to do those things. But if I was a collaborative practice hygienist out in rural Minnesota, that would pretty much put me at a dead stop. So I would maybe think about that restriction with medically complex patients, that the dentist could, in some teledentistry way, check that patient first. Maybe we talk with the primary physician or nurse practitioner. Nurse practitioners are often most familiar with the patient to get sort of a clearance from both sides before going ahead, but not that they have to actually physically see the patient.
I can speak to a couple things. Thank you for your ideas on that. Within the statute itself, it does not specifically state that the medically compromised patient has to first be examined by the dentist, but it does make reference that there has to be specific protocols in place for the medically compromised patient. So I think more so where we were going with this collaboration with different healthcare providers was to have assistance with those medically compromised patients that you are treating, more so than having them have any say on dental conditions that are present. So we wouldn't want to educate them on the dental conditions, but more so since they're working, side by side with these medical professionals within the same building, that often those medical professionals are the ones who are the primary care providers for the patients that you're treating. So it's more so from, a medical consultation standpoint. Our whole intent is to have collaboration between dentists and dental hygienists, but unfortunately, it's appearing that most of the collaborative agreements that are out there, oftentimes it's more just signing a formal document, and there may not be any consultation going, between the two, which that is not the intent at all of this. But I think to start with, we would just maybe have a team approach and have dentists and other healthcare providers be able to, work as a team on a collaborative agreement.
Thanks, Rachel. So these are all proposed changes to the statute. So the action item out of this is, will you bringing a bill forward? How is this? These are proposals, but what's the actual action that's going to come out of this? So how do you see that happening? And do you see organizations like we're at here today at the Oral Health Coalition, and do you see that as the avenue, or are there other avenues? Or just curious, with all this work, what's the action then?
So we are bringing this forward this next legislative term. Currently, the information is being shared with other stakeholders out there besides our Collaborative Dental Hygiene Practice Advisory Committee that has been meeting every couple of months. You know, even today it's being presented to the Minnesota Dental Association, and there's various organizations. So I think we're just gonna all work together and come up with maybe some modifications to our proposals and bring them forward and lobby for those changes.
And that's why you're here today too. That's why you will be completing the survey, because we really want your input. Because already I can tell through this discussion that you've got an insight and a direction to go to say, hey, think about this, and we appreciate this, because now the feedback that you give us today, lots of room for comments. Please give your insight. We'd really appreciate it. And like Rachel said, we would move ahead as a team. Here you go.
Thanks very much. What are the estimates in terms of the increased number of patients that would be able to be seen? And what are the fiscal savings associated with the proposals, if any?
Okay. I'm not sure if we have statistics, data specifically on that yet, so we may have to go back and follow up and see if we do. I'm going to ask anybody else know, Claire, you're working closely with us on the committee, any specific data saying, you know, we would be that much more powerful with our ability to give access to care that you can recall?
Claire Larkin, Minnesota Department of Health, but longtime involvement with the collaborative agreement initiative. Joe, one of the concerns is that we don't have the data because the billing has not been able to generate data. So we really have, I shouldn't say we, but the state of Minnesota doesn't have numbers to provide. And so one of the things that is a conversation that happens a lot of times at the advisory group meeting is whether or not, where is the next initiative to have the conversations with the funders, the payers? And so the issues that we don't know really how many hygienists are out there practicing with a collaborative agreement. If they're not billing, there's no data generated. And when the numbers are looked at by, Laura can speak to this, Laura McLean from the MDH Office of Rural Health and Primary Care, that the numbers that they generated from their data, it looks like there are, I don't know, Laura, how many collaborative agreements? 100 some, or? Let's have Laura speak to that.
So we've been trying to track that through our surveys of licensed dental hygienists. And a lot of people actually say they don't know if they have a collaborative agreement. The few that do, it seems like they're working possibly for health partners due to another issue with doing x-rays, that they thought they needed it in their office. So, I mean, that's another issue maybe Claire can speak to a little more clearly. But we really don't have any idea. So I'll just trade it back and forth. How many people are doing it very well? And, you know, we do know there aren't many dentists out there that take medical assistance, and especially in the rural areas, there aren't enough dentists in general. So, you know, I think we can see that there is a need for more dental care in general.
Okay. Joe, did that answer your question?
Well, I mean, I think we don't have, at Delta Dental, we don't have we have the dentist, the TIN, the tax ID number, we have the provider license, but we don't have we don't know whether the dentist performed the service, or whether a hygienist performed the service, or whether there was a collaborative practice agreement in place. So I thought maybe, we don't have enough data. And I thought maybe at Delta Dental, we have the claims data that the dentist, who the dentist was, who the patient was, what the procedure was, but we don't have the information about whether the procedure was performed by a hygienist or whether there's a collaborative practice arrangement. I think it might be helpful in talking to the legislature to be able to identify, even if they're estimates based on something, you know, that they're estimates of this is how many collaborative practice agreements we're aware of. That helps increase access by X, Y, or Z, and that it would provide some, in addition to additional access, it would provide additional savings to the state, particularly on public programs in some measure.
And I think that's kind of where we're trying to go, is to get that data through requiring registration of the collaborative agreements so that you can track some of that, how many collaborative agreements are out there. If we had the direct billing for the dental hygienist, then we would know they are providing the services, and specifically, what services are they providing and where are they providing them. I believe it was in 2009 when the Minnesota Department of Health sent out a survey to dental professionals in Minnesota, and that's what Laura was referencing. Some of the responses were very startling because a lot of responders said, I don't know if I'm practicing in a collaborative agreement. So really there's just a lack of education on this potential avenue amongst many of the dental professionals in Minnesota. And then in addition, I think we could look at, there's around 40 other states throughout the United States that allow some form of direct access to a dental hygienist. And that was with some of my research. I was looking at other states, and that's where, a lot of these proposed changes kind of started from, according to what other states are doing. So I think we could look to other states that are doing it well to see, how much has it increased access for their residents. Oh, sorry.
My name is Darcy. I'm yet another MDH person here. But I am in the Health Policy Division and am staffing a work group looking at rural oral health and wanting to make recommendations. Colleen Brickle is on our group. But one of the questions that's come up, and I've heard different interpretations of this, and we still need to kind of get DHS to give us their interpretation, but in rural Minnesota, in many places, it's still, the dominant model is a solo or duo practitioner in private practice, of course. And there's questions about can those dentists, private practice dentists, have a collaborative agreement, and send out dental hygienists out, or does it have to be a nonprofit or a health facility? Is there, it seems like there's maybe DHS is interpreting it. Anyway, I just wondered what your interpretation of that was.
I believe, and maybe Claire, you can let me know if I speak incorrectly, but I believe, yes, that they could, as long as they are going off-site, the dental hygienist, and they are providing services to underserved Minnesotans, is really the primary factor here with this. If it's within the traditional dental office, they're really just working under general supervision, so a collaborative agreement is not needed. And I think that's where, I'll briefly speak to the radiation piece, but our data has been skewed on the number of collaborative agreements out there because many large dental organizations, private practice, I guess you could consider them as, have been developing collaborative agreements with their dental hygienists only for the fact that it would allow their dental hygienist to expose x-rays on a new patient without that patient first needing to be seen by the dentist. So I think there was some misunderstanding of the radiation protocols, but a lot of dental hygienists were establishing these collaborative agreements, which were messing with all of our data. So we just don't have a clear understanding of how many are out there. But yes, I believe that they can form a collaborative agreement as long as they're going off-site and serving under. Yep. Yes, exactly. Yep.
That leads to my question that I had about the change in allowing a collaborative agreement without the dentist agreeing to be the dentist of record. And maybe that was taken out because of the change of physician or nurse practitioner.
It's never existed. It just hasn't been clear. So currently, dentists have not been responsible for taking patients as. No, they're not responsible, but it's not. It's not clearly stated in the statutes. And since it wasn't clearly stated, people were hesitant, or dentists were hesitant, because they. Yes.
So what's happening to the people that are identified needing care, follow-up care?
That's where you have to try to find some type of collaboration with a organization who is willing to take referrals from you. And I think that really goes to our biggest piece, which is proposed change 11, which has to do with the billing. And if that doesn't get changed, this is going to remain an underutilized type of practice. Any other questions before we move on to the survey?
Pat Lenton, University of Minnesota. So my question is, and maybe I was misinformed, I was under the impression that hygienists who were in collaborative management agreements had a provider number and that they could directly bill, but that's not true?
At one point, yes. Correct.
And that was taken away? Okay.
So we are still listed as a state that allows direct reimbursement on the ADHA's website. However, as I looked into that further with my research, I realized that that no longer exists. So they used to give those MPI numbers out to dental hygienists, and that no longer is something that is done. So I'm not sure where that went with DHS and.
It's gonna be hard to track the data
Yes.
without that.
Mhm.
So my question is, when we did have direct reimbursement abilities, we had problems with the insurance provider recognizing us, and we'd still have to bill through the dentist or the provider's office. How are you planning to address that with the new changes, with the insurance providers?
I do not have a direct plan to address that, but I am aware that in other states that is an issue. There are states that allow direct reimbursement, and as you said, some insurance plans will reimburse and some do not see the dental hygienist as a provider and will not reimburse to them. So, you know, it will still probably involve a dentist for some time until things can roll over, but at least that might allow the ability for the dental hygienist to be directly reimbursed with some of the billing that is done to specific programs. Oh, okay. So with the survey, it is a two-sided survey. We ask that everyone complete questions 1 through 15, which trickle onto the back side of the survey. There's also a slot where you can optionally place your name and email address if you would like to receive some updates from us or links to some of the resources that we're creating. On the very back of the survey, there is a section that's for dental hygienists only. So if you could please at least do 1 through 15, and if you are a dental hygienist, complete the section on the back. Thank you.